before we record?
We'll do one at the end. We'll do one at the end. Okay, Rachel, if you'd like to introduce, then we will get going.
Yeah, I would be honored to introduce our speaker today, Dr. Nagla Karim. She is a medical oncologist, and I do want her to correct me. Nagla, are you currently in Washington, D.C.?
Yes, I am in Washington, D.C.
Okay.
University.
Wonderful. So she is currently based out of Washington, D.C., here in the United States. She received her medical degree from Cairo University of Medicine, and she has been in practice for more than 20 years.
30
years. That's confusing. You are only 30 years old.
Yeah. I was born as an oncologist.
A true passion.
Yeah.
So her focus is on lung cancer, obviously with the big emphasis on lung neuroendocrine tumors. And she's also involved with clinical and translational research, especially phase 1 clinical trials. We are so thankful to have her here today. She's so consistent every year giving us updates, especially in the realm of lung neuroendocrine tumors, which I know is very personal to here to our group. So without further ado, Dr. Karim, take it away.
Thank you so much. I'm going to share my screen. And as usual, I'm very, very excited to be with you. I'm always, oh, that went away, the title. But we know we're going to talk about the thoracic neuroendocrine tumors today. And these are my disclosures. Next would be, so today I thought I'm going to talk to you about a case first to show you how important it is, really to relate our science to the patients and patients' needs, because there are areas of unmet need there that we really have to work on. We can't just, let it go. So this is a patient that I've seen several years ago. 65-year-old gentleman with excellent performance status, no comorbidities whatsoever, had an incidental right lower lobe lung mass on a CT scan done because patient had like another reason for scanning, just going for diverticulitis. But then because of that suspicious looking mass, patient went ahead and had a right lower lobe lobectomy, showing atypical carcinoid. And we're going to talk about those types of neuroendocrine tumors that arise in the lung. It was staged as T2N2. That goes to the lymph nodes, M0. I know that for us, of course, the question was, should we give treatment after that? Because it's the lymph nodes were, were involved. I really didn't want to give chemo because like carcinoid is always not that much responsive to chemo. But anyways, it was high risk and two, nobody knows what to do. So patient was also very anxious. I don't blame him. Had 4 cycles of adjuvant cisplatin etoposide, and that's based on, the data that's available. You don't have any other good data. So basically, based on this, actually, I worked more on research and, looked into more of like 80 abstracts, analyzed 11 of them with final analysis, evaluated the nodal and Ki-67 status within all those literature. And basically, there was no definitive evidence that adjuvant chemotherapy per se is giving a survival benefit in typical or atypical carcinoids. The status of adjuvant therapy in atypical carcinoid is a consideration within the NCCN guidelines. I mean, even though we don't have a lot of information. So that's an area of unmet need that, we're really working on. So first line, unfortunately, patient, of course, progressed very fast and, treated with lanreotide, and unfortunately also did not contribute to a clinical trial, which we had at that time for thoracic neuroendocrine tumors, because patient went to like endocrinology and the drug is already available outside the clinical trials. So just FYI. Yeah, so that's the abstract I was just telling you about. Okay, so let's go into the real lecture. So neuroendocrine tumors are rare, they're slow-growing tumors, and they basically account for 1 to 2%, and we're going to talk about high numbers, low numbers. So yes, of course, it's not a lot of all cancers. However, those neuroendocrine tumors basically are getting to be more detected in the recent years because, of course, we have better imaging techniques. So NETs, even though that we say that they arise from different places of the body, pancreatic, gastrointestinal tract, and so on, even though the pancreatic and GI account for 60%, which is the majority, still we cannot ignore the thoracic neuroendocrine tumors because they account for third of those, tumors. So even though that lung cancer is common, but even though that thoracic neuroendocrine tumors are only 2%, however, they're third of all the neuroendocrine tumors. So they are important to discuss. The spectrum, it goes to one of diffuse idiopathic pulmonary neuroendocrine cell hyperplasia, DIPNIC, which we talked about previously in the previous lectures. And these are just like some hyperplasia that occurs here and there within the bronchioles, can cause irritation, cough. There's typical carcinoid, atypical carcinoid, large cell neuroendocrine carcinoma, and small cell lung cancer. And basically, as I mentioned, because now we have more of lung cancer screening programs, even though the lung cancer screening programs are more for smokers, but in some areas of the world, they're for everybody. Maybe that the detection of neuroendocrine tumors can happen. Plus, also, some people would go, as I mentioned, for that patient for other reasons, and they get screened, they get a scan, and they find neuroendocrine tumors. So it could be a lot of times as an incidental finding, or if it is arising from the center, it will cause irritation, causing symptoms like cough, hemoptysis, like coughing blood, shortness of breath, or so on. So that's easy. So as I mentioned, basically a third of those neuroendocrine tumors arise from the lung, 32.5% of all those tumors, and they can metastatize basically in 27%. So we're just talking that it is important that we evaluate where they're coming from and if they are metastatic or loculated. Why is that? That's because it will affect our treatment and management strategies. DIPNIC that I was just telling you about, it's this proliferation. As you see, lots of cells here proliferating, but they're multiple. They're very small. They're tumorlets like really tiny, less than 5 millimeter by definition. And their generalized proliferation, and basically they could be a precursor to later on development of carcinoid, atypical carcinoid. They're not really associated with increased instance of small cell lung cancer, but they can cause cough, shortness of breath, wheezing. They can be like an irritating problem with obliterative bronchiolitis. And that's basically submucosal fibrosis. Of course, we don't like that. So, it's good that, we pay attention. And some of it, of course, if it's somatostatin, sort of like receptive, we can get that under control. So the rest, typical carcinoid, it's a well differentiated. The mitotic index would be less than 2. Ki67 usually is low, of course. It's well differentiated. As you see here, the tumor has time to differentiate, to become uniform, to be very close to normal cells with abundant granules in it, because it has time to do that architecture. So it's well differentiated. It's less likely that it is malignant. The atypical carcinoid, the difference is it is more proliferating. The mitotic index, which is the proliferation here, is between 2 to 10. So it's not as bad as the poorly differentiated, more than 10. It could be like 100% of Ki67, but it's still, in between. The atypical carcinoid is worse than typical carcinoid. The neuroendocrine carcinomas that include large cell neuroendocrine cancer and small cell lung cancer, They are abnormal looking cells. They lack normal tissue structures. I'll talk more about them as we go. They have irregular nuclei, less granules. They have less time to draw, less time to proliferate. They are more malignant, and they are more bothersome, of course, with their prognosis and, survival and all that. So most carcinoid tumors, they arise from the large bronchial tubes in the lungs. Third of those patients get to be asymptomatic. So remember, third and third. So third of neuroendocrine tumors are from the lung. Third of them are asymptomatic, and the disease is identified just incidentally by just a scan obtained for other reasons. If they are symptomatic, indeed, they will be in the middle where the bronchi are, those airways. They can have cough, they can have wheezing, shortness of breath, chest pain, especially at taking a deep breath, like pleurisy. Large carcinoids can cause blockage, and they can cause pneumonia. They can be, a problem that the pneumonia can keep coming back. So that's a big reason that we have to, take um, biopsy and really evaluate that. Carcinoid syndrome can happen more in the GI net, but also can happen here in our thoracic part. So can cause flushing, can cause those hyperpigmentation, diarrhea. It's less common, as I mentioned, compared to the pancreatic and GI, but still we need to ask our patients about those carcinoid syndrome symptoms. Rare cases can have ACTH or all those secretory granules and so on, and that can also have sequelae of hormonal imbalance. As I mentioned before, look at the well-differentiated, the poorly differentiated, and the poorly differentiated is like the more aggressive cancer. And the typical carcinoid and atypical carcinoid, they occur like in the 60s. Large cell and small cell usually more like towards the 70s. Women tend to have more of those typical and atypical carcinoids. Male, more of large cell neuroendocrine and small cell cancers, but also those are associated with smoking. And I mentioned about the mitotic figures and the necrosis, which happens more with the more poorly differentiated and more aggressive. All of them will have the synaptophysin, the chromogranin, all those neuroendocrine expressive, sort of stains, the CD56 in particular. And also, they can be combined with non-small cell lung cancer if they are more aggressive, but less likely with the typical and atypical carcinoids. Surgery is the mainstay of treatment because this is a curative intent, especially if it's a small lesion. People can have segmentectomy, they can have like a wedge resection or even lobectomy, depends on the size of the tumor and, of course, on the symptoms. So, looking into when I talked to you maybe last time and this time, what are the treatment strategies? So, of course, if it's a local disease, surgery would be doing that. If it's locally advanced, yes, of course, sometimes surgery, if it's like an obstruction, something like that. But otherwise, there are systemic therapies and liver-directed therapies for metastatic disease. So chemotherapy, targeted therapy, radioligand therapy, and that is the lanreotide, the SSA. So let's move into what advances happen. So remember, I've been with you since, was it before the pandemic? We were also talking together. So we were together here. So I think I like it that every time I add to my presentation more advances and more optimism. So in 1982, there was not much like streptozocin. I did use it. I was actually, was it? Yeah, in the early 2000s, I treated patients. Octreotide, I've used, of course, that. I've used those for some of my neuroendocrine patients in the older days. 2011, I was already done with my all residency fellowship and all that. So the newer were the everolimus. It became approved, and I'll talk about it for thoracic neuroendocrine tumor. This is the only approved systemic therapy. For the pancreatic NET, the sunitinib is the one. 2014 lanreotide, of course, and we still use. And I'll talk about it. The gallium dotate PET, of course, was approved here. We didn't know about it in the older days, but only in 2016 it was new. Everolimus, we talked about it. More and more capecitabine, temozolomide, cabozantinib, in other tumor types, ludotate, they came on, but of course, on and on. So the somatostatin analogs in the lung net are no completed prospective study. I was a co-investigator on the only lung net study. Unfortunately, maybe probably a couple of my patients could have been on the study, but they didn't because basically the drug was available outside the study with the endocrinologists. So we didn't have them within the prospective study, which would have been good if all patients went into that, because basically it would have given us, like an approval, more information to treat the rest of the patients. Retrospective study showed activity for those lanreotide and octreotide long-acting. But of course, it's reasonable to start with, especially if the tumor basically have, sort of like activity, or, showing that it's, symptomatic or so on. Based on really retrospective study of 61 patients, 67% had atypical carcinoid and 48 had functioning tumors. And functioning tumors means that they have the carcinoid symptoms. So they were treated with this, somatostatin analogs, lanreotide or octreotide. They had stable disease in 77%, median follow-up of more than 5 years. And overall survival was 58.4 months and median progression-free survival 17.4 months. Of course, we want better, but of course, this is much better than the lung cancer world data. So patients with functioning tumors have significantly longer progression-free survival compared to 17, of course, 28.7 months. And compared to this overall survival, it's much better. So basically, I would say that it improves the most when it has a tumor that has those symptoms or functioning tumor. So randomized phase 3 that I told you about, what kept on ongoing, but of course they had to close it because of lack of accrual. Switching gears, so the Clarinet study, that was the pancreatic, the GI, when they had the serotonin release, the SSA analogs primarily inhibit the tumoral hormone secretion. So that tells you it's not just the somatostatin receptor binding not only for symptoms, but it also inhibits the intracellular tumor serotonin synthesis, which reduces the production, but also can shrink the tumor, which is oral. There's another analog that could be like an oral inhibitor, and more, have been studied in this piece. However, some people can have refractory symptoms. If they have liver metastasis, we look into ablative treatments of those liver metastatic lesions. If there are, peptide receptor radiation therapy for patients with somatostatin receptor positive advanced disease, definitely this is one approach that we also seek. Okay, targeted therapies. I like that. So everolimus, sunitinib, cabozantinib. As I mentioned, everolimus here is the only USA FDA approved treatment option in bronchopulmonary neuroendocrine tumors, has a response rate of only 1.6%, but it has a good disease control. Temozolomide alone or plus capecitabine is a category 2A recommendation. I use it when patients progress on everolimus. So why did patients have to have everolimus as the only approved regimen? It's based on the prospective multi-center RADIANT-4 study, but they had also inside that study sub-analysis, especially for the net of the lung origin. So the post-hoc analysis of the lung subgroup showed that 90 of the 302 patients, so that's a good number, that's maybe a third of them, had primary lung neuroendocrine tumors, where everolimus was basically utilized in 63 patients out of those 90, and 27 patients had like the placebo. Of course, in this day and age, we wouldn't do placebo, but at that time, placebo was, the control. And the median progression-free survival in the everolimus arm was 9.2 months to keep the tumor from progressing, compared to only 3.6 months if they did not receive the everolimus. And more patients actually had tumor shrinkage, and basically it was tolerated. It does have, of course, the side effects of the everolimus, but it was tolerated, and patients, were able to, get that through. Then, what else? If patients progress on everolimus, what else should we use? So, temozolomide plus capecitabine in patients with advanced low grade or intermediate grade. Based on the pancreatic nets, of course, it showed an improvement of, basically temozolomide versus temozolomide and capecitabine, getting it even better to 22.7 months. Based on this data, we sort of like utilize it, but we still need more information on our lung net patients. What about the cabinet study? That's using cabozantinib. And of course, a lot of those studies do placebo. But anyways, we know nowadays that there are some effective therapies in case we do newer studies. So that's the patient characteristics. And in those patient population, they had either well or poorly differentiated tumors. And it was really the data I'm getting you here about their extra pancreatic net. So it could be from lung. So lung constituted in that study 21%. So again, close to like third of them, or little less than the third of those patients who had the cabinet study with cabozantinib were treated with the cabozantinib therapy. Patients had everolimus, of course, because it's approved. Some patients even had the Lu 177, so that's a nuclear medicine dotate study, maybe 58%. And some had temozolomide and capecitabine. Remember, we said that can be used. And platinum, cisplatin etoposide or carboetoposide, as we are treating small cell lung cancer. Of course, if we have all those therapies, I wouldn't use it, but basically in the past, yes, of course, that's one. So look at that. Even though they're extra pancreatic, the capecitabine, the median progression-free survival was 8.3 months compared to 3.2 months. So it took them way longer time to progress. And this was about a year to follow up. So patients did actually show a much improvement and control of their disease if using cabozantinib. So that's, again, looking at, the 8.2 months, and it's statistically significant, of course, with the continuing follow-up. The radiographic response, basically partial remission in, 6 out of the 33 patients, so only 2%. But a lot of patients kept stable, so 73% compared to 31%. And basically 4% progressed compared to 8%. So basically, showing also the adverse events, more of cabo, of course, maybe the fatigue, the hypertension. Diarrhea is, I wouldn't say much increase, because 7%, even if they didn't get the cabozantinib, and the palmar plantar erythrodiesis is just like a sort of like redness in the palms. And the cabinet study showed responses, continued to show response. So this is the pancreatic, this is the extra pancreatic. Even the pancreatic, it was 18% response rate. Extra pancreatic was 4%, still better than nothing. So these were basically the numbers in comparison with the pancreatic net. These are the adverse events, as I mentioned, looking into all those, basically grade 3 and 4. Really looking into possible the fatigue and the hypertension, and other, of course, looking at the lymphopenias and all the other. We are aware about the cabo side effects. Switching gears to Lu dotate, NETR1, which is like a nuclear medicine. It gives through our radiation oncology division. It does improve the progression-free survival in patients, but mainly it was focused on the mid-gut neuroendocrine tumors. Again, as you saw in the previous study, a lot of investigators and patients tend to get the data from the pancreatic or the GI. It's not dedicated to the lung study. So basically, looking here, the patients had even complete remission in 5.3%, 37.7%, so even higher response rates, and also the disease control rate of way higher because it's the stable disease 47 plus 37%. So overall response rate of 43%, which is way better. If we think of high dose octreotide, it's way less, 9.3% compared to 43%. Again, this is with the pancreatic, and we always know about pancreatic or mid-duct that mid-gut net that they have more responses and more activity than the lung. But again, it seems to be one of those promising agents. Looking at cytopenias, which is, we have to look at the blood counts because patients can have lower white blood cell count. They have a little bit of nausea or fatigue, elevated liver functions, and also hair thinning, alopecia, renal insufficiency. And MDS, very rare, less than 4%, ML less than 1%. We just have to follow their blood counts and so on. For highly aggressive atypical lung NETs, we still continue to consider platinum etoposide as we are treating the small cell lung cancer. And of course, if it's more indolent. So these are basically, the ones we said, of course, everolimus, temozolomide plus capecitabine, capecitabine plus oxaliplatin, capecitabine plus those doxils. Painful bone metastasis, we also refer for radiation for, getting that. And SBRT for solitary or little bit of oligometastatic disease or bone disease. These are ongoing active studies looking, of course, at, we said SPINET, of course, had to close. It had progression-free survival of 16.6 versus 13.6 months of progression-free survival. Atypical and typical carcinoids, atypical carcinoid 13.8 versus 11 months. Of course, lenalidomide, that was the phase 3 study reported here. And of course, the temozolomide and capecitabine showing a progression-free survival 13 months, which is, very close to the lenalidomide. Temozolomide again, and Lu-177 dotate showing a better progression-free survival 18.5 months. And basically showing, of course, that typical carcinoid has even a better outcome. For PD-1 agents in lung neuroendocrine neoplasms, looks like Pembro and anti-PD-1 and Nivo-Epi. These are ongoing studies, but possible some have some reported PFS, progression-free survival that's just getting there with overall response rate maybe promising of 16.7%, Nivo-Epi even better of 33% in those dual immunotherapy regimens, and ongoing studies that we will look at. Switching gears to the more aggressive type, which is, good now that we're towards the middle of our talk. The large cell neuroendocrine cancers, they are more aggressive. They're not typical on atypical carcinoid. As you see, they have more mitotic figures. And they're 3% of all lung cancers. Their 5-year survival is 15 to 20%. So that's worse, of course, than all the other types. And older adults tend to have it with smoking history. And 50%, around half of those patients will have metastatic disease at diagnosis. It is different basically because it has those P53 and RB1, so it's a little similar to small cell lung cancer with the genomic profile. But basically the subtypes might have some differences. This is not very well studied. They just had some data about the mutational pattern. Some express mutational pattern close to non-small cell lung cancer, and some others express it like small cell lung cancer. So that's why it's very tricky when it comes to our systemic therapy. cis etoposide or platinum etoposide, when we use for small cell lung cancer versus large cell neuroendocrine tumors, you find that basically that large cell neuroendocrine, yeah, maybe um, the small cell lung cancer you have like higher responses, but basically it's something that's also very poor when it comes to large cell neuroendocrine cancer, because it's not as small cell lung cancer, but at the same time it doesn't respond as well to chemotherapy. Some were treated with ipi-nivo, that it showed even that those patients within the DART study, it was a multi-center study. They had 3 patients only for large cell neuroendocrine cancer, had 66% response rate. 2 out of those 3 patients responded to the ipi-nivo. But again, that's a very small number to make, fundamental changes. So immunotherapy in large cell neuroendocrine may be promising, median overall survival 12 months. We need to do better. We need to have more information to see if we need to add chemotherapy in addition to the dual immunotherapy. So there was a clinical trial that basically, probably now that it was reported 2017, maybe the first time I talked, I didn't include the trial. They included, instead of immunotherapy, carbotaxol, everolimus in addition. So everolimus, of course, as you know, is basically approved for neuroendocrine tumors. Nobody knows a lot about the large cell neuroendocrine, but the carbotaxol and everolimus in this prospective study showed overall response rate of 45%, disease control rate of 74%, median progression-free survival 4.4 months, and median overall survival 9.9 months. Again, it's better in the world of large cell neuroendocrine cancer. Again, looking at CBC cytopenias, which is lower white blood cell count, GI toxicities, which nausea, vomiting, diarrhea, infections. So typical everolimus related side effects basically occurred, but they were in less than 15% of the patients, and mostly are grades 1 and 2. So it looks like it's promising. We need more potent drugs though. There are more selected studies that I went through, oldclinicaltrials.gov. Looks like durva plus carboetoposide, like we're doing in small cell, or atezo plus platinum etoposide that we're doing for small cell. Remember, that's not carcinoid, that's large cell neuroendocrine cancer. So it needs more aggressive treatment. So we're going to see the results of those clinical trials. Advanced pulmonary large cell neuroendocrine cancers, comparing the carboetoposide versus carbotaxol. So should I give them like a non-small cell lung cancer regimen or a small cell lung cancer regimen? So we're looking at the results for that. And also to establish optimal dose, basically study as phase ones. So lots of those phase ones for novel agents are arising. The data showed that pemetrexed has poor outcome because they have higher level of time-delayed synthase, like squamous cell carcinoma of the lung. So I didn't know in the past, maybe we have treated when pemetrexed came up, that's long time ago, but the newer information that maybe I would use better, like small cell lung cancer regimen or a taxane in this patient population. It might not respond to platinum etoposide as strongly as small cell lung cancer. Maybe the taxane is better. We still need to learn more. Okay, last piece of my talk would be for small cell lung cancer. So we should be scared of smoking, because those with aggressive type of tumor, 15% of all lung cancers are small cell lung cancers, and most of those almost most are smokers, and comes central, S with S, central, they come with cough, coughing blood, it's a lot of irritation. And it's really classified into limited stage. If it's limited on one side of the lung, that we can do chemoradiation, or if it's very teeny meeny, we can do surgery. Or metastatic, it's spread all over, we just have to do systemic treatment. So surgery in selected group of patients, if they have only very tiny tumor, T1, or chemoradiation, of course, if it's just limited to one side of the lung, that's between staging T and M, staging stage 1 to 3, can consider chemoradiation. In the past, it was only platinum etoposide. I'm going to show you what happened now, because things have changed, because we have the Adriatic study now. So in addition to just giving chemoradiation at the beginning, we give consolidation, like more of, sort of like additional immunotherapy every 4 weeks of this is durvalumab to give. Because if we continue to do the durvalumab a couple of years, 2 years after the chemoradiation, shows that the overall survival, people are going to live longer. So instead of 33.4 months, they do 55.9 months. So that's a good success in the world of small cell lung cancer. Limited stage, they can live almost double when they get durvalumab after getting the chemo radiation. Progression-free survival, to keep it under control, instead of 9.2 months time to progress, it's doubled. It's almost like 16.6 months. Again, these are all middle numbers. Some people do much better. Some people, progress faster, but it was statistically significant. Side effects basically is like more of those related to the immunotherapy. Possible, could be like a little bit of like more rash, diarrhea, colitis, pneumonitis, radiation pneumonitis, but basically pneumonitis was basically not that much because we do it after the radiation ends. For extensive stage, which is like all over, again, the most successful part is to go do the immunotherapy together with the chemotherapy in those groups of patients, because it showed benefits. Of course, progression-free survival improved probably like a month more, but the overall survival is 2 months more. In this disease, of course, because it's so aggressive, if it increases couple of months more in this, well, we'll tell you more about better drugs coming up. That is a success. So that is I was a studies chair on this. We added instead of giving everybody the same exact treatment, we looked into biomarkers like Schlafen 11. If patients can do the chemoimmunotherapy at the beginning, and then if they're Schlafen 11 positive, we treated them in addition to the IO, gave a PARP inhibitor. And it was feasible to get a biopsy of small cell lung cancer and see the biomarker. Um, Patients did it and no problem. Progression-free survival was better. Of course, it's, sort of like almost from 2.4 to 2.9 months, so not a lot, but still it was better. So based on that, there was another study that based on our study that they looked more into having, in addition to the Schlafen 11, the subtypes, the subtype A, N, and so on. So to make a better predictive biomarker and to make it even stronger, to in addition to the Durva, having Durva plus the PARP inhibitor that is more potent than the one that's used in the S1929, and the inflammatory, of course, looking into just giving them more of dual immunotherapy. Well, that's one. The other thing is based on our study also, that instead of giving everything at the beginning, focusing on the maintenance. So instead of just doing the chemo IO at the beginning, but then those patients in the consolidation, instead of doing IO alone, the investigational arm was adding, in addition to the atezolizumab, lurbi, which is a kind of chemo that's active in small cell lung cancer. And basically, this was improved because it showed that progression-free survival, and that's from the time of finishing the induction treatment, was 5.4 compared to 2.1. And basically, people with liver metastasis, which is the poor prognosis, also seem to benefit from that. And the toxicity was mainly, of course, those febrile neutropenia, infections, and so on, meaning that we really have to pay attention into giving a good supportive treatment, maybe CDK4/6 or growth factors when we treat patients. Well, most exciting now, the DLL3, which is basically targeted therapy against the DLL3 receptor for small cell lung cancer, which is expressed in more than 80% of small cell lung cancer and even large cell neuroendocrine tumors. And the selected, clinical trials adding that tarlatamab, which is bispecific treatment to the durva, showed many promise, and it's going on in limited stage and in extensive stage all over, more and more tarla added. And that is the Delphi 303, which is even a phase one, but it's a maintenance study for extensive stage small cell lung cancer that those patients basically had a median overall survival. Remember, we were all talking about the 12 months, but this one is 25.3 months of a median overall survival when they combine the tarlatamab plus the atezolizumab in small cell lung cancer by that's most recent in February 2026. That was also presented again. So having said that, I will conclude my talk and thank you so much for listening. Happy to answer any questions.
Thank you, Nagla. That was an excellent presentation. I do have a question, but before I ask my question, I wanted to see if anyone else had anything. Well, I'll go ahead. So I was in my office the other day with some of my students in the lab, and we were talking about neuroendocrine tumors really throughout the body. And our lab, as you know, focuses more kind of on the GEP-NENs. And we were talking about this isn't a very scientific question, but we're talking about the naming, and they brought up the term carcinoid and how that's often used, to refer to lung neuroendocrine tumors. So my question was, the GI part of the neuroendocrine tumors are moving away from the term carcinoid. Do you see that happening in the lung, the thoracic field? And what are your thoughts on that? Because carcinoid means cancer-like in German.
Right.
Is the field going to stick with that term?
For the lung, I think we are behind. And I think we should actually do more collaborative work. You're in Alabama, right?
Yes.
I have, so do you know Dr. Maya Khalil? Or like
I
there's,
don't. Do they study? I'm not as familiar with the lung folks.
yeah, I think we should do more because I think a lot of the neuroendocrine focused scientists are focused on the GI.
Yeah.
So all my neuroendocrine, faculty, there are few, of course, in the lung, but they're very, small. I think we need more work in the lung world. Everybody thinks it's like very rare and so on, but that leaves a problem. There are unanswered questions, as I mentioned, like in the area that, and I'm so interested. If somebody else is interested, let me know. I'm so interested in this atypical carcinoid, like getting like the right adjuvant. I mean, if we're not using the correct adjuvant therapy, like we're not really benefiting, the patient. So
Yeah. No, I totally agree. And I started off my PhD focused on lung nets, and then I drifted away from it. But I'd love to go back to it. My other research is on Notch signaling, and for example, delta-like ligand 3 is part of the Notch pathway. And it blows my mind that there's not an explosion of basic science research into Notch signaling with lung nets beyond small cell lung cancer.
yeah,
So I think there's a big need there.
there is a big need. If you like, we should, really talk offline because I have all those, highlighted questions, and I feel like, we should do some work on that. Especially, I'll tell you, like nowadays with all the technology, you have it, and plus also now with the Pragmatica. Um, the clinical trials shouldn't be that complicated. We shouldn't be suffering like the spinet. We should have more of registrational studies to learn from rather than, wait until we have those uh, restrictive inclusion exclusion. Like I lost 3 patients instead of being on the study because they got already the treatment outside the trial.
I
You
see. I
I
see.
could have we could have collected their data and
Yeah.
known from them how they benefited or not benefit or something because
So
they're
that
still
leads me
doing a
to
great
another
job.
question. Yeah, so what is the feasibility like? So for example, at least with the pancreas, I mean, I think this whole true with lung nets too. The preclinical models are lacking.
Yeah.
And so obviously in the lab, one alternative, if you don't have good preclinical models, is to get patient specimens, whether that's in the form of biopsy or taking the tumor out. And that's a challenge, at least with the pancreatic nets, is repeated biopsies, for example, is quite invasive. Can you talk about the feasibility of collecting patient specimens for research for lung net?
Anybody who would have a bank, a tissue bank, that would be the best. So if there is a way that we can collaborate with a tissue bank, then this would be useful to share.
Yeah. I agree. Do you think, when you are involved in designing clinical trials, is it feasible to ask patients for a
Yeah.
biopsy before and after treatment? Is that invasive?
Well, it depends because lung, remember, is different also from GI. So GI, they can have a scope, EUS, things like that. For the lung, now, of course, it's easier because they do EBUS and like the bronchoscopy, but some patients still like getting a biopsy from the lung is not as easy, as getting it from other areas of the body.
Yeah, that makes sense. And how many patients are undergoing surgery where they're even removing it seems like maybe not a lot of patients are undergoing surgery.
Um, I would say it depends. I think a lot will have surgery because if someone is coming in with a lung nodule and they're moving around, no, they will, they will
Get surgery.
they will have some sort of like segmentectomy or so a lot. So we'll have a lot of tissue. Actually, we are more lucky if you're thinking about it, about thoracic neuroendocrine, especially the typical and atypical carcinoid, more than even small cell. Because small cell, they take a teeny biopsy, but carcinoids, mostly they're going to remove the tumor. So we
Oh,
have
so
a lot
that
of
would be a
tissue.
big advantage for
Mhm.
research.
Yep. So that's why we're missing out on something that's so important and so precious.
Ah, that makes sense too, while you're talking about the tumor bank. If these
Yeah.
are being removed and they're being
They
banked
are. They're
somewhere,
sitting there in pathology, doing nothing.
that is a huge resource to tap into
Mhm.
to study these
Yeah.
tumors.
And it has to be international, like talking there, Selena and everybody, because basically you can't just rely on a single center with a teeny meeny number. This is something that you really want to have representation, geographic representation, and representation from a lot of ethnicities, and to look into the subtypes, to look into, sort of like more of biomarkers and things like that. So,
Absolutely. Absolutely. Sonia, go ahead. Sorry, I stole the floor for a while.
That's okay. I'm just going to talk a little bit about my case then. So originally diagnosed or thought that I had asthma, and I asked for a second opinion and went off to a respiratory specialist who then did a bronchoscopy. And he came to the side of my bed with a picture. He said, "It's looking like you've got a carcinoid bronchial tumor." So they did resection, they did a lobectomy and removed that. And 15 years later, when we didn't know at the time, but there was a new tumor that had started to grow beside the staple. They went back to the bank and they pulled out the tumor from 2001 and reanalyzed it, and sure enough, ACTH staining. So I'd ended up with Cushing's syndrome due to the ACTH lung tumor. And it's sort of been an ongoing story. Now, what we're finding is, as patients, we really lack doctors who know about lung nets. And when it comes to dip neck, they all put their hands up and say, "Oh no, you won't have that." And it's global. It really is global, and you got such a small quantity of patients. It does have to work globally. I'd do anything to be able to get onto a trial
yeah.
and find out what's going on.
No, that completely makes sense, and you make great. This is an international effort.
Yeah, there's too few of
Absolutely.
us.
Yeah. I also I also wonder about something like I think that also with the pathology there's a lot of you know, sort of like what would be the primary, because like going to the pancreatic area in the lungs. So I think, you know, you're very unique. I mean, I think everybody's unique, right? So every patient has a story.
Yeah.
Yeah,
I
absolutely.
think
And
that
from the science side of things,
mm,
you know, every patient's case can teach us so much.
yeah.
Oh, yes, I've got the latest one, and it is because I found a pili multi-Gemini in my head.
Mm,
And I'm going, oh my gosh, what next am I going to have?
yeah.
So,
So fascinating. Sonia, you don't have to answer this question, but I'm curious, have you ever undergone any genetic testing?
yes, I have. We looked at men one,
Mm,
but
That was my next question.
genetically, it's not there. But clinically, I show it, and family members have had hyperparathyroidism and parathyroidism. So, yeah,
Very interesting.
mm,
So that might
yes.
be an aspect of it, but it might not. It doesn't sound like it tells the whole story.
Well, also, the genetic testing was I did it in Canada, of course. Um, that that was done several years ago. So now, if I were to do it, are there different chromosomes, different genes that they're looking for or looking at that weren't available before?
Yeah, I mean, Nagla can speak on this too, but from my perspective from the lab, that progress in that realm in the net field has been incredibly
oh,
slow. And to
oh,
be honest,
yeah.
that is a
Yes.
huge push. There needs to be new indicators, but I haven't seen good advances in new genes being detected.
Right.
That could
We have a
be
lot
indicated.
of advances in non-small cell lung cancer. Like we have to get the molecular profiling before I treat any patient because of the so many findings. Basically, only third of people, but like like a lot of, like half of the patients we have to give like, you know, whatever targeted immunotherapy, whatever. The third are low PDL1 or no mutations or all that. And then we keep discovering every time. For small cell lung cancer, I remember I showed like our study that we looked at like SLFN11, there are the subtypes, there are, but then still we're trying to get the medicines that would be like make them as a predictive biomarker rather than just not, you know, nothing. Even the DLL3, even though that we had a progress for a personalized approach therapy for small cell, they went back and they said you don't have to test for DLL3, and they're giving this bispecific for everybody. But it's 80%, but they still say because it has more patients, you know. So I wasn't sure, you know. Um, I'm like, we really need to work on that. I think that it will be very successful if we get neuroendocrine tumors to have um, the problem with that is that they're very rare. So classifying the rare into rarer or rarest is also a problem. So
Yeah, yeah, that makes it tough. But our international efforts, when we all come together,
yeah,
give me hope.
true.
Yep.
All
Wow.
right. Well, I think we can wrap it up there. Selena, is there anything you'd like to say?
No, I love that you come back each year, Nago. It's been great with the progress. It's fantastic following on your research and your it's been really interesting. It's been a few years now that so it's great because each year it's a little bit more and hopefully a little bit more next year. And yeah, as you mentioned earlier about international, obviously that is what Net Cancer Foundation is meant to do. We're trying to just get people together from all around the globe. So once the that's why we put the videos and things on our YouTube. And we have got there's another the View Medi. I haven't quite managed to get on that myself yet, but we did have, me, Rachel and Kate had a meeting with them, and so that is aimed just to doctors and researchers. So hopefully we can reach even more people, and obviously that we can then try and make contact between everyone. So fingers crossed, we'll get there eventually. But anyway, thank you so much for your talk, giving us your time. Fantastic. And thank you everyone for coming, and good luck, Sonia. We are thinking of you. Keep us updated, let us know how you get on, and we hopefully will see you all next month. So thank you
Thank you very much.
Thank you,
Thank you.
everyone. Thanks. Bye bye.